Good evening, good evening, good evening. This is our Judy Nicholson Kidney Cancer Foundation sponsored panel. And we appreciate and thank you all for joining us on tonight and for your involvement just far. Some of you may be new to this foundation and to Judy Nicholson, and so this will be your first encounter with us. But also some of you are returning or are part of our other groups. And so for those of you that have been here before, welcome once again. Welcome again. I'm just curious. I see quite a few people on already. Say hello to us in the chat, and also tell us where you're from, what city, what state you're from. I'm curious to see how far our reach is so far for this evening. This is while we do have prepared questions and topics to cover. All right, Jacksonville, Florida. I saw that pop up already. Woohoo! And but you also can put questions in the chat and we will address and answer those also. So we are open to questions. This is definitely a dialogue, so please don't hesitate at all to join us. All right, I saw Chicago. Welcome, Chicago. Awesome, awesome. Dallas. Oh, my son's in Dallas. Tell him I said hello. Hi, John. Welcome, John. Hi. Anyone else? Where are we? Oh, another Dallas tag. Oh, Victoria. Hi. Welcome, welcome. Good to see you. All right. Let's see. Illinois. All right. All right. So we're well spread out tonight. Poland. I think that's the furthest. That one wins. I saw MA. Is that what I just saw? I think it popped up so quickly. All right. All right. So Massachusetts, correct? Now I feel like I'm getting a quiz a little bit. Have to remember real quick where everybody's from. Keep it coming. Say hello. You can also let us know if you are a patient or a caregiver or a clinician in your own right. So without further ado, we are at the 6:31 time frame. So let's go ahead and get started. First, I'd like to introduce our first panel guest, and that is Dr. Ravindra Maharaj. He hails from the Mayo Clinic here in Jacksonville, Florida. And we go back just a little bit. We worked and been colleagues in the past, but remain friends over time. And he is a great person to know as a physician who wears many hats. He's got a specialty, and he knows gerontology, he knows dermatology, he knows oncology, he knows palliative care like the back of his hand. So welcome, Dr. Ravindra Maharaj. Thank you so much for being available to join us on this panel tonight. Would you like to say hi to the group?
Hi, everyone. It's nice to meet you, and thanks for the opportunity to be part of this panel this evening.
Awesome. Awesome. Thank you. Thank you. Next, I'm just going to go right above your head there. At least that's how it's showing on my screen, and introduce to this group Dr. Katie Maples. And she is a pharmacist, a palliative specialist, and a palliative pharmacy specialist. So with no further ado, she also hails here from Jacksonville, Florida. She is at the UF Health Clinic. And if you know UF Health, they have a proton center. They have a booming palliative team. Ask me how I know. And so Katie Maples, Dr. Katie Maples is a pharmacist with that group. And Dr. Maples, would you like to say hello to us?
Hi, good afternoon. I look forward to speaking with the group. One of the parts of my job that I enjoy is education. I think a lot of fears that people have is just from lack of knowledge or from misinformation. So I'm looking forward to what comes from this panel tonight.
Awesome, awesome. And let me just put it out there early. You impress us or do too good of a job here, we will definitely welcome you back. So don't be surprised if we do that. All right, moving right along, right above your head. It's a privilege for me to introduce this next young lady in this way. And this is Dr. Rachel Butler, DNP. Yes. She's been a nurse practitioner and a clinician for many years. So in general, the field of study, I know, is not new at all to her. Palliative care is definitely near and dear to her heart. And she too has worn many hats, many specialties. And I love too that she served many different patient populations. She's bilingual in Spanish. I love to hear and see her work her magic in that arena. I mean, just a jack of all trades. So Dr. Butler, would you say hello to us?
Hello, from your lips to God's ears, right? So not quite doctor yet. Next Wednesday, hopefully, but either way. Thank you all for having me, Jayla. Thank you for the invitation. I love palliative care, love educating patients, clinicians, family members on it. And whatever role I play within healthcare, patient advocacy is always incredibly important to me. And palliative care has been the avenue that's allowed me most to let patients have a voice in their care. So it's a pleasure to be here.
Awesome, awesome. And then, and last but definitely not least whatsoever, again, just win the order of what is on my screen, Allision Hall. And Allision Hall is a licensed clinical social worker specializing in palliative care. And again, I'm talking 20 plus years. I believe it is under about, I feel like when I say that it ages all of us, because I feel like we just like, that can't be possible, but somehow it is, right? So Allision Hall hails from Jacksonville, Florida as well. She does now run as a manager the local palliative care service team. And it is such an honor and a pleasure to have her join us on tonight. Because listen, when I tell you social worker extraordinaire, she is a guru of all kinds of magic. And everything from helping to close the loop and fill in some gaps and holes to just being a great listener and hearer of all things spoken and unspoken. So there you go. And Miss Allison, will you say hello to us?
After all that, thank you. It occurs to me that I'm one of the most lucky people because I've gotten to work with every panelist at some point in my career, which I think is also what makes palliative amazing, is getting to work on a really great team of people and learn from everybody. So I'm excited to be here tonight too and talk with all of you.
All right. So then let's just jump right into it, because I know both the caregivers alike and patients that are here, but also other clinicians. And as we saw, our reach so far was as far as Poland. I would not be surprised if we have others that jump on or throughout our conversation that may ask questions and or share their information as well. So welcome, welcome. I saw another name that just popped up and I'm just gonna blow kisses. All right, so let's just start with the first question. When one of the most common is, gosh, what is palliative care? And if I can give you guys like probably 1 or 2 minutes just to speak on that from your perspective. Again, we have a physician, our nurse practitioner, our pharmacist, and case worker, social worker. Part of what people hear when they hear the word is they don't know what it is, but then they also go, so what do you do? So kind of share with us from that perspective. Dr. Maharaj, can I come back to you?
Sure. So the word palliative comes from the Latin word pallium, which means a cloak or a cover. So we're like an extra layer of support for people, especially who have complicated or serious medical illness. We help make sure everyone's on the same page with information. We help manage distressing symptoms. We help plan for the future, and we provide support both for the individual going through the health issue as well as their support network.
Awesome, awesome. I'm still going to say Dr. Butler. Dr. Butler, any other thoughts? Any other thoughts, or what else would you like to add to that definition?
Sure, yeah. A very wise woman who helped teach me used to describe palliative care as the dash in between diagnosis and maybe not doing so well, right? So maybe getting potentially closer to a transition in someone's care. So once you're diagnosed with any serious illness, that could be an illness that's affecting the brain, the heart, the lung, the kidneys, palliative care is there to support you and your family. So a lot of times in healthcare, you hear one thing from one provider, one thing from another. Our big job is to be a bridge and to help paint a big picture, and really to help you feel as well as possible, both physically, psychosocially, and mentally, while you're going through whatever treatment that's offered to you. And just like Dr. Maharaj said, really helping to plan for the future. So we like to have a couple plan A, plan B, plan C, making sure that we really cover whatever avenue may happen and to help you walk that journey down the avenue that's appropriate for you.
Absolutely. I also describe it as like being a translator, because in medicine, we so habitually use these big medical terms and or just jargon. But somebody needs to really, as you said, be a bridge to not only break down the medical terminology, but just simplify it. If my heart is doing this, how is that also affecting my kidney? How is that affecting my lungs? How do these systems all play a role in their own right, but then also when one is impacted by disease, illness, and treatment options. All right. Ms. Allison, what would you say from a social work perspective?
And I really think the only thing I would add to all of that is I think palliative is probably one of the few groups that ask patients what's important to them. So after they get all of this information and the plan A, plan B, plan C, I think that palliative as a whole is one of the few people that sit down and ask, so what plan do you want? Where do you want to be? What's important to you? What are your goals? And really trying to see how we can manage that, like Rachel said, from multiple perspectives. But I think that instead of trying to put patients in a place and a hope for something they can't get, what can we give them and how can we support them and what is important? I think that's just probably what sets our specialty apart from most of the others.
Okay. All right. Dr. Maples?
I think there's not too much more to add that wasn't already said, but I would say usually when I'm explaining palliative care just very simply to patients or their families, I'll say that it's really quality of life, a focus of quality of life for patients with life-limiting illnesses. So, no matter where you are, I see a lot of patients with, say, sickle cell that might be teenagers. They technically have a life-limiting illness, even if they're at the very beginning part. So it really can span the whole, spectrum of disease. And then the other part I would add is a lot of times this is one of the few specialties that looks at the patient and the whole family unit, and their support system as a whole, not just a floating organ or limb or, where a lot of other medical teams are very siloed. I think palliative care is one of the few that really looks at the whole picture, both medically and just socially, looking at emotional, spiritual, and physical issues with the patient.
And I can definitely guarantee you, as the talk continues, as a pharmacist, they will would not be surprised if questions come into the group, but also I know I have a couple of things that may resonate simply because the confusion and/or polypharmacy as it relates to I am one body, but I have multiple ailments and then cancer, and so when we're talking about medications and treatment plans and things of that nature, a lot of times patients and families are navigating symptom management that comes along within that framework too. So I know we'll cycle back to it and go down that avenue a bit. So thank you. That's also so good and so true. This is about holistic care. And I do know that as you all do as professionals as well, as soon as someone hears the word palliative, the first thing they think is, oh my gosh, they're sending me where? To hospice. And so I always like to, both in my caregiver groups, but also in this forum, want to make sure that we clarify and talk about the difference between the two, always keeping in perspective that umbrella approach to palliative care being all of what you've defined, but as well as recognizing until the day comes that cancer is 100% cured, prevented, abolished, we will have some of our care community members that will then be appropriate for hospice, and that day and that time and that support team will come, and it's appropriate, and one that we want to not shy away from, but clarify and answer questions should those arise as well. But what is your take? And I'll open this to the panel first to say, how do you best differentiate for your clients, customers, patients, families, the difference between the two?
I'd say, in general, sort of
Sure.
basic separation is when you are receiving palliative care, most patients are still actively treating whatever their serious medical illness is. So when we're thinking about a cancer of any type, that patient may
Sure.
still be receiving chemotherapy, radiation, surgery, transfusions, whatever treatment there is to hopefully prolong someone's life. Palliative care can be a part of your journey during that point because we're trying to manage your symptoms while you are still working to either cure your disease or at least prolong your life. Hospice then becomes appropriate when someone is no longer actively treating their serious medical illness. That may be because there are no longer treatment options that are viable. That may mean that despite being on really great treatment, your cancer continues to blossom. It may mean that your body is saying, I can no longer keep up with the demands of things like chemotherapy and radiation. I'm too weak, I'm too tired, I'm losing too much weight. Or it may just mean you and your family sit down and say, you know what, this has been a really tough journey, and I'm ready to now just concentrate more on my comfort and quality of life and quality time with you all. That's when we transition to hospice care.
Awesome, awesome. And just a reminder to the group, I'll keep going with questions, but definitely make sure if there's any questions that you have, I keep an eye on that chat. So definitely pop anything in there, any questions that you may have as well. I did see a couple too that identified that there's a patient, they are patients and caregivers alike. All right. So with that description then of palliative care, and I've had people say, well, where did it come from? Because of course we hear, we've heard about hospice. People have said, I'm very familiar with hospice, but so if palliative care is a thing now, why would I choose one over the other? And so palliative just seems like it came out of nowhere. I always describe it, as I said earlier, as that big arching umbrella of services and care. I think you did a great job, Dr. Butler, of describing that piece of that this is incongruent, or it is congruent with your treatment plan and care. Because again, as many of the patients and caregivers on the line can attest to, whether it's nausea, whether it's diarrhea, I know our audience again is a kidney cancer audience, and kidney cancer in and of itself. I always describe cancer first too, though. So let me hit on that. And then I'll pose this back to the group, but I always describe cancer as this rogue cell. We all have rogue cells in our body, a cell that didn't get an assignment, so to speak. And every cell in our body should have an assignment and know what it's doing. Whether you're a hair cell, a nail, fingernail cell, an immune system cell, a skin cell, every cell in our body has an assignment. And when there is a rogue cell without an assignment, it alone doesn't know what to do, but because cells are so minute and of no big harm, should though that cell continue to replicate and make buddies of its own and form either a mass or a tumor and invade a system, if it gets large enough and or impacts or interferes enough with that system's function, now you have what we know as disease. And because of that, then the body then shows signs and symptoms of that disease, because of that system is no longer functioning to its full or appropriate capacity. So then we start working through treatment plans to eradicate this mass, also defined as cancer. And whatever system it's in, you hear breast cancer, lung cancer, kidney cancer. But the goal of treatment then is to, you next hear of biopsies, and that identifies the cancer cell, which helps identify treatment plans and recommendations for surgery or, chemotherapy, what is the best approach for managing that disease. So whether we're talking kidney specific cancer as it relates to this community, or cancer in general, or disease, Dr. Butler alluded to that earlier, that they're, disease in general. Some palliative patients, not all palliative or hospice patients are cancer patients. There are multiple things that can impact and affect the body. So with that being said, kind of understanding, Dr. Maharaj, you mentioned that learning and education process and having those sit-down conversations. As a palliative care physician, what are some of the ways that you find most impactful for patients and families to engage and be educated about their disease and really become advocates?
So I think a lot of times, as you said, many people have apprehension when they hear the word palliative. So I kind of start off by saying that, our team is here to help even while they're having active symptoms. So quite often we would see patients who are followed by their oncologist, and they may have distressing symptoms, pain, nausea, vomiting, lack of appetite, poor sleep, lack of energy. And the oncologist toolkit doesn't necessarily fully address all those symptoms, or they may start initial treatment and they may get stuck, and then the patient, and by extension their family, gets distressed we tend to focus on that quality of life aspect. So we lend that layer of support to help manage symptoms well, so that one, they can tolerate treatment a lot better, that they can continue to try to treat. And if it is that, there is an association with the treatment, we talk with the oncologist to see if something else can be done, maybe modification of the treatment. We also help earlier on in terms of like just making sure we have a plan for the future. And I know I'll leave that on the Allison's table to talk more about like the advanced directives and stuff. The whole point is just to make sure we keep that person in focus of care. There is a saying that I joke about with patients. And again, I say all these things just to, number one, let them know that we're not here to shorten anyone's life or to, to stop treatment. We're just there to be that extra layer of support. So I make the joke that specialists know more and more about less and less, in that they are focused on their organ of interest. For us in palliative care, we're focused on the person as a whole. So we try to make sure that their life, their priorities, their quality of life is all maintained as best as they can as they're going through this journey with respect to treatment of the underlying disease process. So I think once someone sees what the team can do for them in terms of managing their symptoms, managing distress, improving communication between the teams, educating themselves and their loved ones about the disease process, what to expect from it, what to look out for, quite often we become pretty integrated in the team, and the patients actually say that we are probably some of the best advocates for them during this whole process.
And I do love that, because when you talk about the team approach, it's not just a palliative team. One of the things that I love that palliative in and of itself will do, and Dr. Butler alluded to it earlier with that bridge, not only just a bridge of information, but sometimes it's helpful to get, and I think you may have seen it, you may have said it too, the different groups that are communicating and or involved in the patient's care. They're looking at their system. And I can't think of the number of times a patient has said to me,
talking about when you're getting your license yet.
we got to mute. We got to mute. Linda, will you mute them, the group as a whole, so we can unmute when we're sharing? And so I think what we're also then looking at is, thank you. So what we're also looking at then is when we have these multiple providers, families will say, well, the doctor came in this morning, said everything looked good, and I'm fine and doing better, or things are looking better. And then the next doctor came in and said, oh, I'm concerned about this. And so they find that there's this inconsistency in what this perceived inconsistency, or may be valid, if they're not getting that true holistic picture of their healthcare from all the providers. And it can also create an emotional roller coaster. So to kind of punt the ball in your court, Allison, Dr. Maharaj kind of opened that door for me to do that. How do we then look at this emotional roller coaster and or invest in that holistic approach, again, getting all the information from the different doctors, but then now taking that information, digesting it, and then as a family unit, how do you breach those, and I say difficult conversations, not so much even talking about end of life or death or dying. I mean, hard decisions can be, do I do surgery? Am I, and again, this is a kidney cancer community. I know multiple times our guests or our community, our cancer community will say, well, we had to look at, we're doing surgery first, or we're going to go straight to chemotherapy. And I've got one kidney now, and I've got to look at other, how I take medications, or how there's a lot of decisions and discussion that now come into play, as well as life disruption, because there's multiple meetings and visits and doctor's visits and decisions. So how then do we look at that emotional roller coaster and toil? And while she's talking, Dr. Maples, I'll give you a heads up. I'm going to ask about some of these medication polypharmacy, symptom management things that may come up with it, but also the conversation that come up about medications, antidepressants, things that we may hear or consider during that time. So emotional connections and family breaching those conversations. Miss Allison, what are your thoughts?
Such an easy question, Jayla. I feel like I think
I
a
have
lot
a
of that.
cancer community who I know is eager to
Right.
hear. Yes.
I think that roller coaster just so much depends on where the patient is. And I think that's also a lot
Yeah.
of what palliative does too. Sometimes we get to be there right at diagnosis, right? And so the emotional weight of a scary word, a scary diagnosis, all
Sure.
the unknowns that come with that, 1,000 doctors walking into the room. And I think that's what the social workers bring to that is just trying to help understand what have you heard today, and just allowing the patient to kind of teach back to us what's been said and what they've understood. And I think we can also bridge that back to the physicians too, um, encouraging patients, and as probably everybody on this panel knows, having more than one person in the room as they're hearing the information, because it can get so overwhelming and come from so many different places. And especially when you're thinking about surgery and chemo and all of that, like I do think to what we were talking about earlier with all the different organs, you've got oncology saying one thing and surgeons saying another. And it's not that they're at odds, which I think is an easy thing to think. It's just that they are looking at it from their perspective. And so that emotional roller coaster then is that constant, which doctor do I trust? And I think at the end of the day, you can trust all of them, but they're looking from their perspective and just trying to sort through that part. But along with that too, in medicine, it's pretty rare that in the hospital they're not going to have something to offer. And so
Sure.
that's the extra part too, is what is important to you as a patient? What do you value? This pathway may come with surgery and a guaranteed cure. Okay, let's do that. But if it comes with maybe a cure, but you're really going to be in the hospital a whole lot longer and it could involve a lot more pain and suffering, that's a different conversation. And the where do they want to be? Who do they want to be with? Is there a goal? Is there something we want to go to? So I think all those things just play so much in that roller coaster of all of it. So, and I joke with Dr. Maples that even though she's a pharmacist, she is a social worker at heart too. And being able to, when patients are in such extreme pain, I don't know that that's always recognized in the magnitude that it has for patients and families, and they're not really able to make good decisions because they're so focused on that pain. And
Yeah.
so we are so fortunate to have her on our team. Even this past Monday, got a patient, I mean, so much more better controlled than we had done in weeks in the hospital. So she's able to do that. And then we can come in and have these conversations. So it's really that whole picture approach still.
Well, Dr. Maples, it sounds like that ball just got tapped into your direction.
Yeah.
And so, with that, what are some of the things as a pharmacist when you get engaged with patients and families and you're looking at their med profile, their plan of care, this surgery plan, or whether they're in an outpatient setting or in the hospital? How do you then, what are some of the first things you encounter or common questions you encounter from families in general? And then how do you broach some of these conversations, whether it's, you know, whether the team is consulting you regarding emotional coping adjustments? And I usually mean medications. Are we at a point for medication management? And how do you then wrap into this picture?
Right. I think kind of tying into what Allison was saying, really the first step is knowing what our goals are.
Absolutely.
To come up with a treatment plan if you don't really know what the goals of the patient and their family together are. So for example, sometimes in an ideal world, we would have, 100%, pain relief or symptom relief with 0 side effects, is the ultimate goal. But most of the time we can't reach that goal. So where if something has to give, where's it going to give? So is it, if you lay this out and really the patient and their family are the only ones that can decide what is right for them, is it, okay, I'm, being awake and alert and being able to, interact with my family is very important. And if that comes at maybe having to have a little bit less medication for my pain and other symptoms because it makes me drowsy, I'd rather do that versus, another situation or another patient might say, if I have to sleep a little more, if I'm not as able to be as active, having my pain controlled or being able to sleep or being able to do things, to stay comfortable is what my first priority is. So really it comes down to what the goals and what the priorities are for an individual patient and their family. And as far as pain specifically, I think I try to spend as much time as I can initially kind of talking to the patient and going over not just their medical history, but just really their history as a whole. Because with palliative, like I mentioned before, when we talk about pain, we talk about total pain. So there's emotional pain, there's physical pain, and there's spiritual pain.
Good point.
Probably for me, one of the biggest examples of how emotional pain can tie in, and present differently. At a different job, I worked at another hospital, more of a acute type pain service, and we had this elderly patient. She had fallen and broken both of her wrists and hands. Had never been on pain medication before, but nothing they gave her would work to keep her pain controlled. So they called in our pharmacy pain service to take a look. And after talking with her a little bit, I found out that she was a piano player for her church and was about to go to Israel on this once in a lifetime trip, to have this concert. And now she doesn't know, one, she won't be able to go to the trip, but will she ever be able to go again, which is her livelihood. And so once we kind of identified this is really an emotional pain, there's physical pain there from surgery, but a lot of this uncontrolled, issue is more of an emotional pain. Her brain just knows she has 10 out of 10 pain. It doesn't know what the source is. So once we addressed those symptoms of more that anxiety, her physical pain was very easy to control. And I think sometimes we'll see that, especially in the hospital, people will come in because their pain's uncontrolled, and things will kind of escalate and snowball. And it's really picking apart what came first, what's a side effect of something else that happened, and then really looking at what are we actually treating. And it might not always be medicine. Maybe it's talking to a chaplain or, someone in your church. Maybe it's unresolved issues within your family, and kind of working those out. So I think the physical symptoms that you can put your hand on are really only a piece of what, as palliative that we usually address that adds to, symptom management.
What you're talking about is true holistic medicine, holistic practice. All I can think of as you're speaking is just a testimony of how connected our body is, mind, body, spirit. This is not just a physical journey that we're on. Family members who've been on, on some of our caregiver sessions, who they're watching their loved one go through and they're very supportive there, but they in their own right forget about their own care and daily routine because the focus has been so shifted. And the patient then also feels, is that I don't want to be a burden and I want to do this, and role reversal or roles being redefined because of treatment plans and or certain limitations. You've got to take it easy. All of those things outside of just the physical manifestation do have a true place in the plan of care discussion. And that is so much of what palliative care is, in addition to into that piece of if I can get this. I got one more. There we go. Thank you so much. All right. And so with that thought, or that, again, that holistic approach to knowing when to have these conversations, we don't expect people to have the total answer or even realize or recognize that that's part of the journey in palliative medicine, that holistic picture. I say it oftentimes on our care group. As soon as I start, I say, okay, all right, everybody, how's things going? What's been going since our last meeting? We just allow the immediate update of, well, my husband or my family member, they immediately go into the updates about the patient, the caregiver, the loved one who's going on the cancer journey. And then at the end of that, I'll pause and say, so then how are you? And that's also part of that palliative picture, that total picture. It's not just the patient, the disease. We don't want to just talk about the disease. We need to normalize what a new normal may look like for this shortened and or long journey of this treatment journey. And so that's always important too. So I love that. As you were talking about that, that's all I kept thinking is, yes, the body is so interconnected. We are just one big chemical reaction after another, and emotions play a huge part in that. Anybody else, any other thoughts about that piece? Then I'm going to go to one of the questions that we have here. Let's see. I saw a few questions about pain medication and the thoughts about herbal treatments and or acupuncture or non-pharmaceutical options. So I'll open that to the group, and naturally, Dr. Maples, I know at some point it'll circle back to you, but anybody have any experience and or thoughts about non-pharmaceutical treatment? What would they call it? Not, I want to say contemporary, but that's not what is it?
There's complementary and
Complementary.
alternative.
That's what I want. My head was saying contemporary, and I'm like, it is not contemporary. Yes, complementary. So these non-pharmaceutical things, but then also there's a question about about different herbals and or vitamin regimens or what have you. So I'll open it back to the group.
I'll just generally say I took an integrative palliative medicine course a couple of months ago, and it was enlightening. I wish I could say that as a provider, I have actually implemented some of this. I haven't. Working in most US hospitals, particularly where we are and not in the Midwest, a lot of our therapies are going to be your very standard medical traditional therapies. I do think there is a role for complementary and integrative medicine, whether that's through acupuncture, massage, Reiki, touch, essential oils, marijuana, right? There are all sorts of other treatments that I think can be a wonderful adjunct, meaning maybe something goes well with the traditional therapies that you're on. So I'll turn that over to you guys, but just in general, yes, there's a place for it. I think it's important to make sure whatever you're trying, you're hopefully trying it with a professional who is well-versed in that, because just like a medical professional can mess up something traditionally, if they're not an expert in that traditional medicine, the same can be said for some of the complementary and alternative therapies.
And I think adding on what Rachel said, kind of communicating with your care team is very important. So just because sometimes the effects of some of these complementary therapies can not necessarily, sometimes can interact with traditional medication and treatments, or also there can be effects of one. And if we're not really sure what else going on, we're not really sure what it can attribute to. So especially if you're talking about herbal supplements, over the counter, anything like that, it's really important to talk to either, if you have a pharmacist that you fill all your regular medications, with, or if you're on, a team, like a palliative care service, either in the hospital or outside, just making sure someone knows the whole picture of what's going on. I think sometimes people feel a little, I don't know if embarrassed or shy, kind of talking about non-traditional medications, herbal supplements and everything, but it is important because some can, counteract prescription medications, can make them work, less effectively, or just have some kind of interaction, even if it is plant-based or something that's herbal. And it also is important to have a reputable source with whatever you're getting, just because there isn't that same level of inspection and just kind of quality control that there are in some of the more, FDA approved regulated medications. But I will say, before the job I was at now, I worked at the Navy base, and I actually got certified in acupuncture. So I think some of the, insurances are starting to go forward with covering these kind of services, for both, in the VA, like veterans circles, a lot will have access to certain kind of acupuncture, massage, things that were traditionally not, covered services that people had to pay out of pocket for. So it's good to look at, whatever your insurance provider is to see, and you might be surprised what services might be covered if you're not currently in a, hospice or palliative care program.
Service. And that's a really good point. I think with the advancement of technology in medicine and research, I know right here at the Judy Nicholson Foundation, we're huge on partnering with other cancer associations, and both here in the US and abroad, which is, it's the most important way for us to be able to share information, but also look at what treatment and research options are here. Our goal is, we know kidney cancer is one of the most common cancers incidentally found because it doesn't have any screening markers up front. It doesn't have any tests or anything that you would do pre diagnoses. And generally, when found incidentally, it's usually at a more advanced stage, but it's still a fairly highly treatable disease. So again, that's a really good thing. However, again, we're one body, and whatever your other comorbidities or other ailments, medical diagnoses, medical condition, your baseline health status, all of that plays a part in your overall journey and how and what that may look like. And again, with advancement of technology, I think palliative care not only is being more openly shared and accepted, more hospitals and or clinics are reaching out to professionals such as palliative teams to help bridge these gaps, that term, again, using that term again, but also looking for ways to ensure that these services are available, whether it's insurance-based or otherwise. So I agree with you. We're seeing this more and more out in the community, and I love that. I love that. And even from other partners that we hear of in other states, they may share with us what we've been doing this for years, and it's like, oh, I'm soaking it up. So with that, one of the questions that came from one of our other groups was, so with all of this information, I'm not a clinician. How do I empower and or find, get my physician or my team, my medical team, to be open to these conversations and or find these resources? I know one of the first things I'll say is we try to post things on our Judy Nicholson website, and the internet has a plethora of information, but how do we then promote? Because I know too, not all providers are as educated about hospice and palliative in general, and this holistic approach for some. I mean, palliative care has been around in the U.S. now for 60 plus years, so not a totally new concept, but look how long it's taken to even get to where it is now. So positive things we're seeing, but I'll go back to the question. Is there any thoughts about then, where patients and or families, caregivers, how do they get this topic or this introduction going within their medical team, and then look at resources to be able to support their goals and wishes?
I actually was going to steal a line from Dr. Maharaj, so he doesn't know this, but one of the things that we really empower patients to ask here, and especially if you don't have a palliative team readily accessible to you wherever you are, is I think no matter what physician you're using, he would always suggest that we use three questions, and we give that to every patient. But what's better, what's worse, and what do they expect to happen? And it doesn't matter what doctor walks in the room, even if they're not palliative, if a patient is asking better, worse, and expected, it does naturally empower that physician to think a little differently and think more broadly. So if the resource of just a robust palliative team isn't where you live, I think just those three questions alone help tremendously to get the information that you need. And then, I mean, obviously in the world of the internet, you can do all kinds of things, but the Center for Advancement of Palliative Care, which is CAPC, you'll find a lot of information on that website. But the trick then too is just to not rely totally on social media for your information. So if you are Googling and looking for information, stay on more reputable websites, medical websites, Mayo, Johns Hopkins, all of the hospitals. Try to avoid Instagram and Facebook as our source of information. So,
And
so unless it's a really good site like Judy Nicholson.
Yes.
There's others though. I mean, so again, and I think the key there is reputable sites. We want to make sure, because people post opinionated things, but definitely you want to make sure you're connecting with resources and finding groups that are actually going to be data-based, and then too, don't implement or try anything unless you've shared it with your provider and you all are on the same page. I think someone else was chiming in.
And I think it's important, kind of like what Allison alluded to, is, being empowered to bring that up to your team. I don't know how many times I've talked to a physician to say, hey, what do you think about introducing palliative care? Or this is what I'm thinking. And they'll say that they're hesitant. They're not sure if the family's at the place to accept that, or if they just kind of want to keep giving hope are afraid of giving a realistic, picture of what's really going on. So I think by the patient and their caregiver and family starting with those questions, it kind of empowers their provider to say, okay, I can walk through this door, because it's already been opened for me. So that can be important for if you don't have a palliative service to help kind of push people through the door. It'll help you to kind of open that door.
I'll jump in as well to say that I agree with Jayla. A lot of times the providers may not even think about palliative care. And there may be a few reasons for that. One of which is, a lot of times the providers have a long relationship with their patients, and admitting sometimes that they need extra help, they may see it as a personal sign of weakness to ask for someone else to help with the other symptoms and planning for the future. Even if things are not going well, a lot of times providers may volunteer another treatment instead of saying, let's stop and have a conversation about where you want to go moving forward. So there has been a sort of public relations push in the palliative care world for patients and families to ask for palliative care. And sometimes just asking, just saying, is there a palliative care doctor that can help me? I have some symptoms that aren't being addressed. I have some more questions. I want to explore expectations. Just ask. If your given provider is not aware or doesn't want to involve palliative care, you can always just bring it up. And there are those reputable sites like Alison had said. CAPSEED, Center for Advancement of Palliative Care, is one. Any of the major university websites could be another source, and you can always show your provider that information. If you go into a hospital, a lot of hospitals, at least in the Jacksonville area, have an embedded palliative care service. So it all depends on where you are. If you're in a smaller, more rural area, or your closest health facility is a community hospital, they may not be aware, but then you could find resources online. I think CAPSEED is a good starting point.
One of the things that I do credit COVID for, or the pandemic for, is that it forced us to get into telehealth and telemedicine. And not that it was new or that it didn't exist before, but it really pivoted it into a whole nother dimension as far as it being more user-friendly, more accepted, more ways to do it in a HIPAA compliant way. And even in our support group, some of the caregivers who do live in rural areas, rural states, who have very few specialists, especially as it relates to cancer, oncology, kidney cancers, any of that, and very few specialists, urology specialists, they were able to either get connected with other providers who could do telehealth and get updated, request records, provide feedback, and likewise joining support groups. I think every time we're on the caregiver support group, it's not so much for me as a provider or any of our other moderators to be the experts. Yes, we're there for the clinical support, but who better to help you think outside of the box and or navigate than someone who's also gone through the journey. So it's not that you're circumventing your providers. Just recently, we were on a call in one of our sessions, and one of the caregivers was describing almost exactly what another caregiver's loved one was experiencing. And they said, hey, did your doctor check this lab? And it's not that the physician doesn't know these things are out there, but sometimes it is the needle in the haystack. And because of familiarity and things that you all may discover just in conversation, it may spark a conversation or a thought just from an advocacy standpoint. And just a little note for you to jot down to be able to share with your provider and say, hey, what are your thoughts about this, and or to ask a question. So again, that advocacy standpoint, that getting information in the beginning, it will definitely feel overwhelming because there's so much that you will learn about how the body should work, but then also what happens when it's not doing what it normally can. And so having specialists and folks like the palliative team is hugely helpful because, again, here's that word again, having that bridge, not just from provider to provider, but also information. And that's so huge because information is everything and things change along that journey. Go ahead, Dr. Maharaj.
I wanted to just add one more thing.
Sure.
Doctors are driven by evidence and research and the medical literature, right? So in the past, many people would associate palliative care with hospice. So the mindset of the provider would be, this person they're at a point where nothing can be done, then let's think about comfort, right? Now in 2010, there was a study by a provider called Jennifer Tamel, who looked at people who had metastatic lung cancer, and they found this group of people and they divided that group into two. One group had the standard cancer care. The other group had standard cancer care plus the addition of palliative care. What was not surprising was that the group with the palliative care addition had better quality of life, because that's what we do. We manage symptoms. We make sure everybody's on the same page. What surprised the researchers was that the group with palliative care lived longer with better quality of life than the folks who had standard cancer care. So that sort of busted the myth of palliative care meaning, on hospice meaning potentially just end of life care, and actually showed that we were a vital part of the team to help the person along the journey while they're actually having treatment being done. So if it is that you do get resistance from your given provider, you can always say that there's actually research that shows that in addition to helping my quality of life, palliative care can actually potentially give me more time. Now, when you look on television, you may see there are certain anti-cancer immunotherapy agents saying that they can promise you 3 months extra of time. And, there's always the cost and all these things involved in these medicines. Palliative care is a service. So if palliative care was a drug, people would be lining up to get that medication, if I had to say that, right? It's just that the stigma of the name, I think, has kept many people from getting connected with us. Just to remind you that we're just here to be your support and to make your life feel better, make sure everybody's communicating, and also to keep you in the driver's seat. If you leave things up to us as providers, more often than not, we tend to try to run the show. Having a palliative care team involved makes sure that you remain in the driver's seat.
Yeah, that makes me think. You hit on another thing, and then I think I saw Dr. Maples about to chime in too. I see someone asking a question about the link to the information you're providing, Dr. Maharaj. But in your comment just now made me think of, and I wrote it out here, the 7 C's of palliative care: communication, coordination, compassion, collaboration, continuity of care, continuous learning, and care in dying. Because again, palliative is the big umbrella term. Hospice is just yet a piece of that. So not when people hear the word palliative, because too, a lot of times that word starts coming up when you're having a lot of pain, or maybe your worst day, or just not doing well. Again, palliative in and of itself does not have a declaration for an end of life or dying process in it. Palliative care is truly, as Dr. Maharaj mentioned, it's a covering. It's an overlapping of services and care that look at the totality of the picture. Are medications contributing to the symptoms? Is your chemotherapy treating your cancer, but the side effects causing you more complications? Do we need to look at, are you on adequate medications, back, as Dr. Maples was saying, to help offset the symptoms that are associated with the medication, or does the medication need to be changed? And so when you're looking at those holistic kind of questions, because there are some certain cancers that have very few chemo options, and so stopping the chemotherapy may not be the recommendation, but treating the symptoms and or doing things to tune up the body prior to the next cycle to ensure a better outcome is also part of the goal there. So very good. And I did see Dr. Maharaj share that in the chat there. We'll also link it on the page too, so that if you have additional questions there, you're able to look at that study and or any others. We're quickly approaching the 7:30 timeframe here, so I want to I'll pose another question to the group, but I also want to open it to our guests and those of you that are joining. If there's another question or anything that you'd like to place in the chat, please do that. Awesome. And so we'll look at this piece of it. So we'll share information. But from the group, any other comments or thoughts before we get ready to wrap up here?
I think just kind of parroting what, both Allison and Dr. Maharaj had said, as far as it's important to really ask very direct questions to your care team. If they say, okay, this treatment can give you an extra 6 months of life, asking, well, what are those 6 months going to look like? Am I going to be in the hospital, withering away? Am I going to be at Disney World with my family? What is kind of the best case and the worst case? Because really, I think people and their families aren't able to make fully informed decisions unless they have all the information. And sometimes when, like Dr. Maharaj says, sometimes if a provider has a close relationship with the patient and their family, they might feel like they're helping them by maybe not giving a clear picture of what is going to go on. But really it's hurting because the patient can't really make an informed decision without having all the information. And sometimes you have to be the one to initiate, if the provider isn't offering that information, up front.
Absolutely. Absolutely. And it also makes me think of, again, going back to that holistic picture and how important communication is. When you're doing your searches, when you've had time to process and digest the information that you did hear. Some providers are comfortable allowing you to record when they're explaining very complex information, or if they're really giving you results or options for a treatment plan. If your provider, and I would always say ask if you're able to record just that piece of it, so that when you follow up with your family and you're trying to regurgitate this information, they can hear what the physician, the provider said. They can also, as you should too, write down questions or any points of clarity that you may need. I like Allison's 3 points, if I remember it correctly. Say that again, what was it? What are you expecting?
It's better, what's worse, and what do you expect to happen?
There you go. Because when a doctor gives you, oh, the tumor did this, were you expecting it to? Is that surprising to you? Is that good? Is that bad? Again, you didn't go to medical school for years. This is new. And even if you had another loved one with, say there's a familial, or your family has a history of cancer, one loved one may not have had the same cancer and or responded in the same way. So you should not have the expectation that your loved one is going to respond and or have the same journey as someone else. So going back to those 3 questions is very important. What's better, what's worse, and what do you expect can definitely be helpful. And then just a reminder, we talked about this in one of our groups. This has come up a few times, and even one of our caregivers in the group said, gosh, I'm going to use this with my teenagers. Remember, when it comes to that communication within your family unit or whoever your support system, things that you find difficult saying out loud or conversations you both are still a little clumsy with as far as conversations, write them down, put them in a receptacle for that other person, allow them to respond back to you. I love keeping like little index cards and things like that around. Write your questions and or conversation, allow them to write the answer back. Writing allows you to kind of center, to be quiet, but also to get your point out without being interrupted. And then you both can exchange. So those are just some things, some food for thought. This has been what I hope for you has been very helpful, and at least the beginning of more discussion and conversation. Please check out the Judy Nicholson Foundation page and or go to our website. We'll have those posted in the comments for you because you'll find other recordings and other sessions, symposiums. We've traveled and we partner with other specialists. There's information about research. There's information about nutrition. You name it. We didn't really get into living wills and health surrogates, but there's information out there about that as well. And so we want to make sure that we connect you with these resources. I see a few things popping in the chat as well about tools and resources for you all to have. So please soak it all up. And on the page, please let us know what other topics and things you'd like for us to talk about. So if there are no other questions, thank you so much to our panelists, Dr. Maharaj, Dr. Butler, Allision Hall, Dr. Maples. Thank you for sharing your time with us tonight. And to all of you, thank you so much for joining us. Our thoughts and prayers are with you and your families. And let's keep kicking cancer's butt. Thank you, guys. Have a wonderful, wonderful night.